Good morning. I think we should get underway. This session, number 2 in the plenary, is on coronary artery bypass grafting, the champ's opinion. And the first speaker will be Jim Paulus, who's had considerable experience with total arterial revascularization and has published on this problem in the past. So, thank you, Jim.
Thank you. It's a great pleasure to be here. Dear colleagues, I'd like to make some comments based on lessons learned from almost 40 years of using arterial grafts and how they have informed our surgical strategies. I have no disclosures, and I'd like to acknowledge my colleague and friend Brian Buxton and the surgeons from the University of Melbourne hospitals that have helped to accumulate this experience. So we began to use arterial grafts back in 1980 when we were both a bit younger. But over the last 40 years, the hospitals I've worked at and my colleagues have done about 30,000 coronary bypass procedures, with the vast majority of multiple arterial grafts and about 80% total arterial revascularization rate. So based on that experience, I'd just really like to make some comments over the next 15 or so minutes. So firstly, with the internal thoracic arteries, everybody uses them, especially the left. Over the course of the last 40 years, we've discovered that skeletonized arteries are better, they are longer, they have a bigger diameter, a huge flow, and also you do preserve the sternal blood supply, and there's fewer infections. So here's an example of a skeletonized left internal mammary artery. You can sort of see it reaches right down to the diaphragm, and with that you can readily perform sequential diagonal to LAD anastomosis if you need to, or use it as a baby Y graft if need be. Similarly, with the skeletonized right internal thoracic artery, you can see by skeletonization it achieves a much greater length, and it becomes a very versatile and very useful conduit. The skeletonized vessel, you can see we've got excess length in this video, and it shows the excellent flow and the way you can readily prepare it for anastomosis. So it's certainly wider and easier to use. Moreover, by having skeletonized techniques, you can specifically divide the branches as seen in the right upper part of this slide, and preserve the blood supply, leave the blood supply to the sternum intact, and thereby have a much better chance of having close to zero sternal infection rate. And this is seen diagrammatically here, with the white line being where we would divide the branches running to the intercostal vessels, and hence preserve the flow of blood from the intercostal artery from the right to the left to the sternum itself. This has again been scientifically shown in a number of studies where the blood supply to the sternum is preserved much better if the vessels are skeletonized than if used as regular pedicle grafts. So I would emphasize very strongly the very, very versatile use of the skeletonized blood vessels. Also, there's been some controversy whether they get damaged or the patencies are different. In our experience of roughly about 20,000 bilateral mammary cases, they have identical patencies, whether it's skeletonized or pedicled. The other feature of mammary arteries is that the distal part is very, not only is it smaller, but it's very spasmogenic. So then if it's possible, we try to discard that bit. Sometimes we do use it for little Y grafts. But you can see in the bottom left that the distal ITA is quite small and much smaller than equivalent to radial artery. So we definitely tried not to use that if we can avoid it. Moving to the right internal thoracic artery, my message would be if all cardiac surgeons can take down the left internal thoracic artery, there's absolutely no reason why you can't take down the right. It's the same, biologically identical. It's usually larger, and it's actually easier to take down. It's just a matter of devoting that extra half hour to do it and the mindset to do so. So it's an excellent conduit. So here it is as a skeletonized conduit about to be passed through the transverse sinus to the high marginal intermediate setting. So using it as an attached skeletonized in situ graft, it will readily reach the upper half of the lateral wall of the heart. If you wish it to go further, then obviously you have to use it either as a free graft or as a Y graft. So we've found the skeletonized right internal thoracic artery a very versatile graft, and by being skeletonized, again, it's much larger and much easier to use. So alternatively, we do use it as a free graft, either to the posterior descending or to the distal circumflex marginal. Now, there's been controversy about whether the free or in situ right internal thoracic artery has any difference in patency. And in over 1,000 post-operative angiograms at a mean of 7 years, we found the patency of the in situ right internal thoracic artery identical to that of the free right internal thoracic artery. So I think from our point of view, the lesson learned is that you use it to the best possible position for that particular patient. Easier to do it as an in situ graft, but certainly use it as a free graft. The other thing we've learned is that the patency of the right internal thoracic artery is if it's placed to the same vessel with the same conditions, is identical to that of the leader. So everyone thinks that the leader is fantastic, which it is, with a patency rate of over 95% at 5 and 10 years. Well, the patency of the right internal thoracic artery is identical. It's just that we normally use it to lesser vessels like the circumflex marginal or occasionally the posterior descending. But when used to the same vessel and under the same conditions, the patencies are absolutely identical. More versatility by using the right internal thoracic artery as a Y graft to reach the distal circumflex and posterior descending, a technique used by many cardiac surgeons, not one of our preferred techniques because we started in a different way. So the way you start and learn is perhaps determines how you do things in the long term. With all grafts, and including the internal thoracic arteries, there's always a hierarchy. Grafts to the LAD, no matter whether they're right internal thoracic artery, radials, or LITA, are always better than the circumflex and always better than the patencies to the distal right coronary artery. So our surgical strategy has been that we use, if we can, the two ITAs to the two best and most important arteries, and usually these are to the left side of the heart, the LAD and the circumflex, and certainly in patients who are younger, less than 70 years of age, and that's young these days. The other thing is that we always avoid using a saphenous vein graft and an arterial graft in the same system unless there's a complete occlusion separating the two. And yes, we do use saphenous vein grafts from time to time. Next, I'll make some comments on the radial artery, and I know most people think that I just use radial arteries and nothing else, but that's not quite true. But we have had a very large experience with radial arteries over the last 25 years, with over 20,000 cases in which radial arteries have been used, and about a third of those we have used bilateral radial arteries. So they are long, they are very easy to use, they're incredibly versatile, and they usually reach anywhere you like. I think important thing to emphasize is that to make it simple to use them exactly as a saphenous vein graft. Same type of technique, the same type of exposure, just one's in the forearm rather than in the leg. We do open harvest rather than endo harvest because of a number of reasons, particularly with the teaching hospital situation, having residents rotate through. But we've been happy with our techniques, and certainly from the literature, the results of endo or open harvest the same. We avoid the instrumented radial artery if we can for at least 3 months, not only because there's trauma at the lower sort of 4 to 5 centimetres, but also the endothelium is often affected by the instrumentation, and the reactivity of the endothelium and the radial arterial wall, although patent, the reactivity is often compromised, and it does not expand to vasodilators. But having said all that, the radial artery, in our view, has been a godsend because it's larger and much easier to use than the right internal thoracic artery, and you can certainly harvest the left radial simultaneously with taking down the leader. So here's an image of a free reta on the left-hand side and the radial on the right, and just see how much bigger and wider the radial is, and thereby much easier for the sort of surgeon starting on this journey, much easier to use than the right internal thoracic artery. So what are some of the problems with the radial? Obviously we wouldn't use if it's trauma or very calcified. You need a good ulnar collateral supply, and certainly for collagen diseases, that's a very real contraindication. We always use an Allen's test, so easy with plethysmography, and make sure that we have good ulnar supply to the index finger, seeing on the bottom panel within 10 seconds, and that's our standard test. We sometimes do ultrasounds on the radial artery if we're concerned about extensive calcification or its size, and certainly we would not use a radial artery if it was less than 2 millimeters in diameter distally. The radial is an excellent size match for most coronaries. On the left to the posterior descending, on the right to the circumflex, you can sort of see a very good size match, and the robustness of the wall makes it easy to handle, and the anastomosis and the hood stays open, making it quite easy to suture. When we do use it, it's mainly a one-to-one conjugate, but if it's appropriate, we would certainly use it as sequential grafting, usually with parallel anastomosis. So I think they're easier to perform, but we do use it as diamond if need be. Proximally, a lot of people have concerns about the proximal anastomosis, both with the reta and also with the radial. In our experience, it's not a problem. We use a 2.8 or a 3.5 millimeter punch, as you would with a vein graft, and sew it directly onto the aorta. If the lie is not suitable because of proximal disease in the proximal marginal, we often use little baby wire grafts, which are very versatile and allow us to graft at the most ideal point. Baby wire grafts are also very, very convenient in the distal right coronary distribution, where we'll often place the main graft to the posterior descending, and then a small further graft, usually of another bit of radial, to the posterior lateral branch, and then do the inflow anastomosis near the acute margin, where it's very straightforward to do. So I do encourage you to consider that. So when do we use the radial artery? Generally as a second graft, and sometimes a third graft of choice. It's especially useful in obese, insulin-dependent diabetics, in reoperations when there's conduit shortage, if the legs are awful, and for the older patients it's terrific because you can get them up and ambulate them. The essential issue of arterial grafts is to avoid spasm and avoid competitive flow, and also to make sure that they're adequate size. And we normally prefer separate inflows. So here's a really example of a radial artery in many areas of spasm, and this is a very real phenomenon and needs to be overcome. The radial is by far the most spasmogenic of the three main arterial conduits, much more than even the gastroepiploic and a lot more than the IMA. So having an anti-spasm prophylaxis program is absolutely essential. Early on, we used to use radials for younger patients to moderately stenosed right coronary arteries, but it took us about 10 years to learn that lesson, and of course that's a no-no today. So what do? We have topical intraluminal papaverine usually, although we've used milrinone and GTN and verapamil. We use intravenous nitroglycerin over the first 24 hours, and there's a bit of evidence that a calcium channel blocker over 6 months is also very useful. There's a lot of controversy about the right internal thoracic artery versus the radial. I think they're both identical in terms of their long-term patencies and results, so it's really just a matter of how you apply them. In our experience, as I mentioned before, the patencies of the three arterial grafts that we use commonly is identical to the LAD, identical to the circumflex marginal, and identical, but though lesser, patencies to the right coronary distribution, mainly because of the competitive flow issues. So the other thing we've discovered with arterial grafts is the production of nitric oxide, which also helps to minimize the occurrence of new disease downstream over the course of time. And these grafts remain totally free of atheroma and look pristine 10 and 20 years later. And here are a couple of angiograms of radial arteries, 22 years post-operatively, showing absolutely no signs of any disease. So in general terms, once these arterial grafts are in place and there's been no technical problem, then basically they stay open forever. So this is our experience based on almost 9,000 post-operative graft angiograms, at a mean of about 7 years. The arterial grafts all have 90% plus patency rates at 15 years, whereas the vein grafts down to 33. And as I mentioned, I think the radials and retas have similar patency. So once they're in place, they stay open forever. And these are a series of bar graphs, about 100 angiograms per year over the course of 10 years for the radials and 20 for the retas, and to show that the patency of each of those yearly groups that have been angiogrammed are in the 90% plus each year. So once they're there and patent and working, they'll stay open forever. So just to finish on the contrast between the radials and the retas, both have similar patencies. The reta is less vulnerable to competitive flow. However, the radial is easier to use and more versatile. So what's our surgical strategy? So we used at least 2 arterial grafts to the best arteries. The easiest, there's no doubt the easiest, is the lead at the LAD and a radial to the circumflex. But in younger patients, ideally, we would use a reta as well to the circumflex. What about the right coronary? That's the difficult issue. For younger patients, for moderate stenosis, we often leave it alone, considering a later stent. If it's very tightly stenosed, we'll use a radial artery. For older patients, then usually a saphenous vein graft, but if we do want to avoid leg incisions, then we would use another radial artery. We have a mild experience with FFR, and also we think that the transit time flow measurements are an important component of making sure that you don't leave the operating room with a graft problem. Are 3 grafts better than 2? There's some mild evidence that may be so, but I think that's early days. So just to finish, the patency results, in our view, translate to better survival. So this is one of our publications that at 10 years, patients that have total arterial revascularization, there's 10 more alive at 10 years per patient, per 100 patients operated on, and that's a very big bonus. Similarly, as treated patients in the ART trial, there were 6 more patients alive per 100 operated at 10 years. And this pertains also to subgroups like diabetics and renal failure. So arterial grafts are excellent conduits. Once they're in place, they remain free of atheroma and have absolutely excellent patencies. For expending an extra 30 to 60 minutes, the average patient probably gets 3 more years of life, and 6 to 10 patients per 100 operated on are alive at 10 years, as opposed to just 1 lemur and saphenous vein grafts. And certainly multiple and total arterial revascularization should be considered for everybody. Thank you.
Thank you very much, Jim, for a very clear and precise and excellent presentation. Could I just lead off and ask you, a lot of surgeons still take down pedicled internal mammary arteries rather than skeletonize them. And one of the arguments used is we don't know the patency. Well, I think we've diffused that. The second one is that the issues with training registrars or trainees to take down a skeletonized IMA. Could you comment on that, thanks?
Well, I think it's a vexed question. There's no doubt it takes longer when you're starting off, but later on when you experience it, it does not, in my view. The way we deal with trainees is to give them a good head start, and if they've got an hour to get going and make sure they start early on. So essentially, we double scrub with trainees and show them what we do and get them to do some of it, and gradually transition from them doing a bit of the skeletonized IMA to doing the whole lot. But I think the way to do it is to allow them sufficient time to do it properly and carefully, and without sort of having the boss over their shoulder, because you've got to finish, you've got to start the next case. So I think it's just a matter of showing them and giving them, being patient and giving them the time.
One question. So I don't use so much the radial, but sometimes I use it, and then I use in the skeletonized fashion, even for the radial. What's your opinion about that?
We don't routinely use it as skeletonized vessel, although we take it with very small amount of perivascular tissue. So basically just take the radial with the 2 veins on either side. We do open the fascia, usually extensively, particularly if we're doing sequential grafting. And occasionally, if we want a bit of extra length, then we will skeletonize it, but skeletonize it on the table after it's been harvested. And that's very easy to do, and you can do it very carefully and very nicely, just move along the artery and take away the veins.
People say that the skeletonized radial is prone to spasm more than the pedicle.
I don't think so, no, not in our experience. I think what you do with skeletonized radial is you get 1, 2, 3 centimetres of extra length. So I think that's the key.
Hi, Professor.
Question?
Yeah. Hi, Professor. This question just came to my mind when we and Mr. Barnett were having a coffee. In terms of spasm of radial artery, do you think there's any difference when we put it on the aorta or we wire it off to the mammary? Do you think the spasm would be a little less when it's directly connected to aorta purely based on the flow?
No, I personally don't think so. I think when you use it as a wire graft, that's an extra technical problem. And I think that you must get the anastomosis and the sequential bits right. But I don't think the Lima radial Y is more spasm prone than coming off the aorta. No, I don't believe so.
Thank you.
Thank you for a very nice overview and presentation. I want to emphasize the point of opening the fascia on the radial. I also do think that makes a difference to the string sign issue. I think some of the string sign issues could be related to some kind of compartment syndrome in there. And there's actually a Danish surgeon, Christensen, who told me about that and showed very nice, a small series where he had compared angiographies with and without.
Yeah, I can't comment on that, but we do open the fascia because it just makes it easier to use, and particularly if you're doing sequentials, it makes it less likely to get adventitia tangled up in the anastomosis. So I think it's a nice technique.
Yeah, and also it allows you to inspect the artery very carefully, and you can really know the quality.
One short question. Is there any place again for gastroepiploic artery, or it's...
Well, unfortunately, we didn't learn that technique. Yes, there is. We use it rarely, but mainly in redo surgery, off-pump redo surgery, when we're revascularizing the inferior part of the heart for a failed right coronary graft. So we just avoid a sternotomy and just use it. Yes, so we do it maybe half a dozen times a year. So thank you.
Thank you very much. Our next speaker is Dr. Niyanami from Tokyo, who on OPCAB for sick left ventricle, state of the art.
Thank you very much. Good afternoon, ladies and gentlemen. This is my title, OPCAB for sick left ventricular function. No COI. So yesterday I presented about the off-pump CABG, and then I personally do like 97% off-pump. And the major benefit of the off-pump CABG is, I think, the high-risk patient, especially like a LV dysfunction patient. So this paper was published by the John Pascal's group and published in the Annals of Thoracic Surgery in 2013. The purpose of their study was to evaluate the outcomes of patients with low ejection fraction, less than 30%, who underwent surgical coronary revascularization with or without cardiopulmonary bypass using the SDA national database. And in conclusion of their result, in the SDA national database, OPCAB associated with a significantly reduced adjusted risk of early morbidity and mortality for patients having CABG with an ejection fraction less than 30%. So early outcome of the OPCAB in this LV dysfunction is quite good. Another paper, this is also published in the Annals of Thoracic Surgery in 2011 from the UK group. In this study, meta-analysis was performed to evaluate the benefit of OPCAB in patients with LV dysfunction over conventional CABG in mortality and morbidity. 23 non-randomized studies were analyzed. So 30-day mortality, OPCAB versus on-pump CABG. OPCAB was 4.2%, and on-pump CABG was 6.4%, which is a statistically significance. Same as for the 30-day myocardial infarction. OPCAB was better compared to the on-pump CABG. However, they said, based on 13 studies, there's no difference in mortality at the midterm. And based on 4 studies, there is no significant difference when comparing late-term mortality. Analysis of 4 studies revealed that OPCAB group was associated with significantly less complete revascularization. So this is a very important message. OPCAB is probably good for early term, but not good for the late term, related to the less complete revascularization. Always, this is a major criticism for why the on-pump CABG is not superior to the conventional CABG, because of the less complete revascularization and less graft patency. So they concluded that in this study, OPCAB may be associated with lower incidence of early mortality and morbidity. However, incomplete revascularization by the OPCAB group occurred more often. It may explain why the early advantage in mortality was not continued to the late term. So I'm going to show you my OPCAB strategy for poor left ventricular function. So I tend to use a elective IBP insertion, not for the day of the surgery, but one day prior to the surgery. Not all of them, but I tend to use this. And some of the patient is a pulmonary hypertension condition. So in that case, I tend to use a inhalation of nitric oxide. Also, there are 2 ways of exposing the heart: deep pericardial stitch, so-called Lima suture technique, and also the apical suction device. But I tend to use a deep pericardial suture because that's easier to lift up the heart for the biggish heart. And complete revascularization, grafting as many as possible, and try to use a bilateral mammary. And the in situ ITA, left ITA or right ITA, to the LAD first for the good perfusion from the anterior wall. And then possible to proximal anastomosis, like a saphenous vein or radial artery, prior to the distal anastomosis for immediate perfusion after each anastomosis, which is safer for the bad LV contraction patients. But do not hesitate to convert. This is a major important message when you use the up-pump CABG for this condition of the patient. And this is a key point for the LV dysfunction patient, complete revascularization. So I analyzed my personal data, the patient data in my previous centers. So the aim of this study was to evaluate the early and the late outcome of OPCAB using bilateral mammary compared with a single ITA for patients with poor left ventricular function. From 2007 to 2017, about 10 years, total was close to 1,300 patients, all OPCAB patients. That time period of the OPCAB rate was 97%. Preoperative ejection fraction less than 30% was 105 cases in this group of patients, all isolated OPCAB. The exclusion criteria is, of course, no cardiopulmonary bypass and also single vessel disease. The single ITA group was 52 cases, and the bilateral mammary cases was 53 cases, almost identical. This is a preoperative characteristic between 2 groups. The age is bilateral group is a little bit younger because they are more arterial for the younger population. Otherwise, 2 groups are almost identical. The operative characteristic in 2 groups. Average distal anastomosis is 3.4 in single mammary group and 3.6 in bilateral mammary group, which is pretty good number because this includes also double vessel disease patient. And the complete revascularization is over 98% in both groups. The prophylactic IBP usage is a little bit more in the bilateral mammary group. The hospital mortality is shown in this slide. Single mammary group, the 2 patients died. The bilateral mammary group is 0 mortality, but there's no difference. So total 2 mortality, about 1.9% mortality. Both cases are emergency cases due to acute coronary syndromes. The early morbidity is shown in the slide. As you see, in 2 groups, there's no difference between 2 groups. This is a post-op echocardiogram within 3 months post-op. Left ventricular diastolic dimension in both groups statistically significantly reduced. However, there's no difference between 2 groups. Ejection fraction is the same. Both groups, 10% ejection fraction increase, however, no difference in between 2 groups. So this is a result of the late term. The late death, no difference between 2 groups. However, the cardiac death, the bilateral mammary group is better than the single mammary group. Same as the cardiac events, bilateral mammary group is better than the single mammary group. We also performed the multivariate analysis for the risk of the cardiac death. As you see, bilateral mammary usage is negative impact factor for the cardiac death. This is the paper published in the Heart and Vessel 2016, predictors of the immediate and the long-term outcome of coronary bypass surgery in patients with left ventricular dysfunction. So this group did not use the OPCAB technique or the conventional technique. But as you see, single mammary group, I mean, the double mammary group is better than the single mammary group for the long-term mortality. So in conclusion, the use of bilateral mammary for myocardial revascularization may be good long-term survival benefit for the poor left ventricular function patient. However, this is the important message. Only for patients whose left ventricular function improves significantly early after surgery. So I look at my data, the multivariate analysis. As you see, post-operative ejection fraction less than 30%, which means no improvement of the ventricular function. This is a high risk for cardiac death. So this is the comparison between the bilateral mammary and the single mammary artery without improving the cardiac function post-op. And there is no difference even using the bilateral mammaries. So I looked at these 29 patients, which is no improvement post-op, ejection fraction less than 30%, compared to the others. So as you see, acute coronary syndrome is actually the no improvement group is lower, and the left ventricular diastolic dimension is much higher, and the ejection fraction is much lower. So this is my today's summary. OPCAB for poor left ventricular function patient is, of course, challenging. Several studies show that OPCAB can be beneficial over conventional CABG. However, complete revascularization must be essential for better long-term result. OPCAB using the bilateral mammary artery for poor left ventricular function patient might be advantageous for late-term result, but only for patients whose left ventricular function improves significantly early after surgery. Thank you very much for your attention.
Thank you very much for an interesting and excellent presentation. Could I ask you, when you What technique do you use to do your proximal anastomosis? Is that with a side clamp, or do you do some other?
I tend to use a heartstring. So it's not complete aortic no touch, but I tend to not to touch the aorta.
Yes, yeah. So that allows you to do multiple anastomoses at different times before each distal.
Yeah, I tend to use a sequential bypass. So.
Yeah. Questions?
Hi, good afternoon. Vaibhav Mishra from India. While I pretty much do what you do in severe LV dysfunction cases, putting IBP 1 day prior, however, for using bilateral mammaries, I do use only in younger patients because many of these, see, you've said severe LV dysfunction, but there are many patients who have this LV dysfunction chronically. One of the territories is dead, scarred. And so you didn't mention about, segregating those patients where the LV has been chronically down, then somebody who's acute dysfunction. What's your take on this? Because many of these patients with arterial grafts will not benefit. That's my point, because if the LV has been down for too long and certain territories are scarred, as happens in many diabetic elderly patients who have severe LV dysfunction, how do you segregate those? Because I purely do it basis of age. You get my question?
No, you mean the...
I mean, you said, one of your points was that only when you think that the LV will recover is when you will do the bilateral mammaries.
When I choose the bilateral mammary?
Yeah, because, so the question
yeah,
here
one indication is, as I shown you, the younger patient, that's true. But not only that, but also there are cases, the poor left ventricular function. So sometimes the artery, even the octogenarian, is quite small. Those cases, it's difficult to have a good patency long term by the saphenous vein graft. So in that case, I tend to use the arterial graft. Of course, the age is one of the factors, but not only the age, but also the target vessel. Is the target vessel small or like a CTO? Those cases, I think they are better to use the arterial graft for the long-term patency. That's the way to choose a bilateral mammary or single mammary artery.
All right, okay, thank you.
Dr. Anbir is from India. I enjoyed your presentation, thank you. Did you correlate your outcome and results with the viability of the myocardium? Because most of these severe LV dysfunction have been ischemic for a long time. A few territories may not be viable in them.
Actually, no. And then there's about 30 patients of my series. Those patients whose ventricular function did not improve. We start sub-analyzing, and those patients, there's not much viability. So maybe those cases are not good candidates, but we have to do something.
Because we get a lot of patients with severe LV and associated ischemic mitral regurgitation.
I mean, the mitral regurg, I do touch if the mitral regurg is the moderate to severe, more like a severe, I touch the mitral, but otherwise I don't touch the mitral.
So most of these severe LVs, we always subject them to a pre-op viability and then take a decision whether to go ahead with surgery or not, because they're poor candidates if the viability is very poor. Thank you.
Yeah, actually, my question is more or less the similar one as the previous one. For those with a poor LV ejection fraction pre-op, I think it's very important to have the myocardial viability test. And in your series, you didn't show that data. So that's one of the concerns. For us, if the viability is not available, probably we will be a little bit more conservative. That's the first thing. Second thing is you said quite a few patients underwent emergency or relatively semi-urgent operation. For those patients, I think one of the criteria is whether the patient got symptom, got chest pain. if the patient presented to you with only the heart failure symptom without the pain, sometimes also it's not a good indication for CABG. What's your comment?
Yeah, I agree. And the first comment, of course, we should analyze the viability test. So that's we have to do now to show this is to investigate more. And I think that's why some of the 29 patients, they don't recover from after the CABG, the ejection fraction wise. Those patients are not emergency cases. That's the chronic the cases. So I think that's the reason why their ventricular function didn't recover. Thank you.
One more question.
Right here. Please, yes.
Yes, please.
Hafil Abdul Ghani from Jakarta, Indonesia. Have you ever looked, or anyone, into gastroepiploic artery utilization and low ejection fractions patients, especially for OPCAB?
I tend to use the gastroepiploic artery. I didn't mention because I just focus on the ITA. But for me, my third conduit, the arterial conduit, is always a gastroepiploic artery. I use like 1/3 of my OPCAB cases. But the gastroepiploic artery is very, very, somehow, it's not the reliable, the conduit compared to the ITA, because it's not very strong, the flow. So it needs to have the very, very critical stenosis. The best target is the PDA, and then more than, I must say, 99% stenosis. So that kind of cases, we use aggressively use the gastroepiploic artery. And if you select the patient with that condition, the gastro is a really good conduit. But the important thing is not to use as a pedicle. Always use a skeletonized fashion. That is very important to use it.
Thank you very much. Enjoy your presentation. Thank you.
Thank you.
So next speaker is Mr. Gardner. Safe Radial CABG.
Actually, with all these arterial grafts, I don't know whether we need redo coronary artery bypass operations. But certainly there's still a lot of patients around since the inception of statins that have survival 20 years plus, maybe with some stents in the late stage, but still surviving with saphenous vein grafts, and some of them will need reoperations. Okay. So, to take a fairly simplistic approach, there's two basic elements in cardiac surgery, isn't there? One, we correct the mechanical problem, which is generally a hydraulic problem of some sort, pipe too big, weak might burst, pipe narrow, valve obstructed, not opening, or valve leaking, at least in adults. So correct the mechanical problem, and the second thing is to protect the myocardium. Now, if we do those two things properly, there's no reason why if the patient's alive at the beginning of the operation, they shouldn't be alive at the end and make a good recovery, providing that we don't create a new problem during the operation. We don't make any mistakes, bad decisions, or errors. And error results from physiological and psychological limitations of humans. We're all vulnerable. Doesn't matter how good you are, it will happen. And we know that in the hazardous technologies that we're involved in, then when we do have adverse events, it's important not just to blame those who have blundered, but look at the systems that back the procedure up. Sorry about that. And of course, it can have significant ramifications, not only in issues with patient safety, but certainly from an economic perspective. So redo coronary artery bypass grafting does carry some additional hazards over a first-time operation. So what we need to do is create an environment where we minimise the possibility of error or misadventure. What are some of these errors? Omissions, judgment, decision, technical issues, lapses of concentration, inattention to detail, none intentional, but potentially preventable. And I think one of the major errors that I think is very important is the error of omissions. Not having all the information and investigations at your fingertips when you're ready to do that operation. So what we're really talking about here is a system of risk management. And with redo coronary surgeries, we know that it is a higher risk procedure. Should it be? Not necessarily. But there are more hazards, and you have to work out as the surgeon what hazards there are in this particular patient, because every patient is different. How do I avoid them? If they do occur, how am I going to deal with them? Is my team informed and ready? Is the patient prepared? You noted with Dr. Niyamama's presentation his importance of his patient preparation in those patients with left ventricular dysfunction. Do I have all the information I need? Critical, because if you don't have all the information that's necessary, you may not have identified the hazards that you're likely to confront. And so this is a standard risk management 5-step process. You identify the hazards, assess the risks, determine controls, implement controls, and then review the outcomes. But I prefer to look at it this way because it's really a circular process, what I call the risk management cycle. So we identify the hazards. We then assess what sort of risks these hazards are going to provide in terms of how likely are they and what is the consequence. Then we need to think about the individual or potential controls that we can employ and assess those with a view to whether they in themselves would produce problems or hazards in themselves. So that having thought that through, it's then defining a plan and implementing those selected risk management controls, and then of course reviewing the outcomes. But as we all know, we will often come across new hazards as we go through these procedures, and these then feed back into the cycle so that we get an ever-increasing understanding and experience that carries us through our professional careers. So the two major issues, of course, here in terms of risk are the restenotomy, and secondly, the management of the heart and the existing grafts. So if we look at the restenotomy, what are the hazards? Well, we've got injury to vital structures, which I've listed there, starting at the top from the innominate vein through to patent grafts, whether they be vein grafts, radial, mammaries, whether they run from the right side to the left, whether the mammary runs over the top or behind the aorta, if it comes around the inside of the lung, which they used to do in the very early stages of mammary surgery, which would sit right in the midline. So these are all things that potentially can be injured. And then you've got injuries to non-vital structures. Okay. So what's the consequence? Injury to vital structures are going to produce hemorrhage and impaired cardiac function, major consequence. Okay. What's the likelihood? Well, to determine that, we need to look at the information that we've got to determine. We can't determine the risk until we've got all the necessary information. So we need the operation report from the previous surgery. Hopefully it's come from either yourself, when it'll be a meticulous descriptive operation report, or elsewhere. I must say that in my experience, the operation reports often generated are almost useless when you come to a reoperation, and I think that's a significant deficiency We need to be precise with our operation reports, describe where the grafts go, have a diagram, describe whether you've closed the pericardium or not, and if so, whether it's one stitch or all the way up, describe where the grafts run. Does the right graft run over the front of the right ventricle? Is it at risk with a reoperation? Where does the right mammary run? Is it along the side of the atrium? Where does it come through in the pericardium, etc.? So all that information is critical. And you need all the relevant investigations the patient's had. You don't want to come off bypass and find there's 2-on-4 MR and then start asking someone, where did we ever have an echo done before? The lateral chest X-ray is very important because it'll give you mostly all the information you need in terms of planning your re-entry procedure. Coronary angiogram, obviously, it's the diagnostic tool that you work out your strategy from. But part of that coronary angiogram is to work out where those grafts are. Now, you notice with the skeletonized mammaries that Jim Tatoulis showed us, you'll have the clips on it and you can determine exactly where those vessels are running with those metal clips on the mammaries. And you need to know that, particularly if you've got a crossover from the right side to the left. Is a CT scan often required? Not really, unless these initial investigations suggested that you may have real issues with the aorta or right ventricle on the back of the sternum. Local knowledge, obviously, if you've done the operation, you'll have a fair idea. If you're a junior surgeon, don't hesitate to contact one of your seniors to get advice with these procedures. Okay. So having done this and having got all this information, you can determine what the risk is of any injury to those vital structures. Here's a lateral chest X-ray, and you can see that clearly that once you get up above that second wire from the bottom, that you will be clear. The other interesting thing to note is that pacing wire is in the innominate vein. Look how close it is to the back of the manubrium. Okay. Another lateral chest X-ray, and if you get above that third lower wire, then you're going to have a clear run through to the top because the aorta is well back. Okay. So how do we manage these risks? Well, I think firstly, the technique of re-entry is absolutely critical and is the most important aspect of it. Secondly, that dependent on your assessment of the risks of injury, then you need to prepare if that risk is deemed to be likely or certain. So in terms of the innominate vein, you must clear behind the manubrium with your finger and push it away. I've certainly divided innominate veins. I suspect just about everyone that's done a re-entry sternotomy has done it at some time. If you do that and clear behind the manubrium with your finger, then it's most unlikely you'll have any problems with the innominate vein. So with the aorta and great vessels, if you've assessed that's a situation where you may enter the aorta or the right ventricle, then you need to prepare the potential for rapid onset of cardiopulmonary bypass. And in rare situations, of course, it may be necessary to go on bypass and cool the patient down before you start to open the sternum. And certainly with patent grafts, again, the importance is to locate them exactly on the sternotomy, where they are and where they're most at risk, so that you can plan your re-entry. So I'd just like to show you this 3-minute video. Shouldn't that play when why isn't that playing? We had it playing before. This is a technique that I've used myself for probably nearly 20 years and that I've found safe, fairly quick and clean. That's it, thanks. Okay, that's it. Playing now. Okay, so here we are just marking for the sternotomy. That's the lower point of the incision. Here we are, we've cleared around the sternal notch, finger around the back, push the innominate artery out of the way. We look here, here's that lower wire. We know that when we get to that point, we'll be clear of the right ventricle. And you can do the same. For example, if you had a crossover right internal mammary that was close to the sternum, you would mark the point on the sternum where you're going to encounter it. Okay. The next step is your assistant will pull up on a bone hook and you'll start to clear behind the Ziffy sternum with Metzenbaum scissors. And the technique is, and they're dividing the xiphoid, the technique with the scissors is to cut, but also a gentle sweeping motion at the same time. So you're clear on either side of the midline. You don't need to go out too far. You need a nice clear tunnel so the saw can pass up without problems. So once you've cleared that little area down the bottom, you can relieve your assistant of having to pull up hard on that bone hook, and you set up your retractor, the rule track, with a single hook and elevate the sternum and continue the dissection. The tips of the scissors need to be kept hard up under the sternum, so you lever the shaft against either the bottom of the incision or your left hand. And with the table elevated and positioned and a headlight, you can actually do a lot of this under direct vision. And it's just gradually moving up. You know, once you get in this particular patient past that spot, the second wire, that you should be clear, and we should have a pretty clear run all the way up. So we just keep working along. At any one point you can stop, put your scissors up and then take them out, and then you'll know exactly where you are. At this point now, we've got the scissors up the top. We can feel them on the tip of your finger, and then you can just wiggle the scissors, open up that little tunnel a little further without damaging anything, and you're ready then to pass the sternal saw. There's nothing special about this. It's any time you run the saw down the sternum, it's pulling up a little, and then when you get up towards the top, just to make sure you haven't picked anything up, come back and go again. Okay. This is important. When you first open it, don't put the retractor in, pull up with a hook gently and clear behind the sternum on each side. Because if you don't, if you put the retractor in and start to open it, you run the risk of splitting the right ventricle open. And I've certainly seen that. So if we move on to the management of the heart and grafts, and really the two issues here, I think, are myocardial protection and how you manage the existing grafts. So myocardial protection, well, I think the issues there, the risks are inadequate or uneven distribution of cardioplegia, and perhaps not so much these days, but certainly in the early days of redo surgery, atheromatous embolization down the coronaries and back into the aortic root was a real risk. And so what are the mechanisms to manage the risk? Well, I think anterograde, obviously, and retrograde cardioplegia is very important. I always thought retrograde cardioplegia was one of the great advances in modern day cardiac surgery. It allowed us to do a lot of complex, difficult procedures with good myocardial protection. It's my practice to dissect out and mobilise the patent arterial grafts that were, and occlude them before administering cardioplegia. Now, I know some surgeons like to leave them intact and leave them perfused, but that was my practice. Certainly you need to mobilise it. So if you've got a lemur to LAD, you need to mobilise it because you won't get access around to the back of the heart easily otherwise. Certainly careful dissection around patent grafts to try and minimise that risk of embolisation, and generally done with cardioplegic arrest if it's under the heart or around the left wall. It was my practice to divide off all the patent diseased vein grafts where we were going to redo that graft, and do that early in the piece and also off the aorta, and use retrograde cardioplegia to back flush into the aorta and back flush up the coronaries. And there would be occasions where you'd see some atheromatous mushy debris come out. And I think that was a very important part of the operation and one of the major risks that you need to deal with. Do you need to take all the vein graft off the heart? Not necessarily, but if it's an easy dissection, why not? And certainly flush out the aorta as well. Is there a place for off-pump surgery? The answer is a yes, but I think it's a small place and in special situations, and I don't think we have time to go into that today. Just in terms of managing the grafts, obviously I've listed here the sort of things that you're going to have to consider and the risks that you may face in terms of quality and available conduit, how you're going to selection and arrange your conduits, your preference going to be for arterial grafts, obviously, and again, thinking in terms of embolization, careful dissection of grafts, obviously your risk management of the ascending aorta with potential atheroma and plaque in that situation, and your cannulation and clamp sites, dealing with an intramyocardial LAD. And I suppose the big question is, well, do we need to replace all patent vein grafts? Should all patent vein grafts be replaced? Well, I think in 1985, Delos Cosgrove wrote a paper and said all grafts older than 5 years should be replaced. And I think in those days we were confronted with this very early atheromatous type of disease in the vein grafts that had a lot of sludge and loose atheroma. And I think that's changed a lot with the advent of statin therapy. I think durability of vein grafts has improved. The type of pathology in them has changed a little, and they're probably more amenable to stenting, which explains a lot of patients now that are 20 years plus that are still free of angina, maybe having had a stent or two at some time during the operation, but still fully functional with an IMA to the LAD and vein grafts. So I think that's a difficult decision. If you've got a reasonably healthy looking vein graft, then you have to consider other things like patient factors, conduit availability and quality. What have you got to replace it with? Remember, whatever you replace it with has got a small incidence of occlusion, early occlusion. This one's currently patent and working. And of course, the native coronaries, a size, disease, amount of myocardium supplied is important. And I just show you this because here's a vein graft that I took this photo in the cath lab of a patient that was 22 years after an operation, and you can see that's a vein graft after 20 years. Now, that's probably a very uncommon situation, but it does happen, bear it in mind. So in summary, I think the important thing is to identify all the risks. Prepare your patient, prepare your team, and prepare your strategy to manage these risks. Make sure you have all the information and patient records and that they're in the operating theatre so you can refer to them immediately if you need to. Use a safe technique for resternotomy, the one I've showed you I've found very safe, and protect the myocardium. So thoughtful risk management will minimise errors and optimise patient outcomes. Thank you.
Thank you very much, Mr. Gardner. Any questions or comments from the audience?
Michael, that was a fantastic lecture. Very important. I want all of my residents in Japan want to listen to you. More critical things like would you prepare for femoral arterial venous line or just set up, or in a higher risk patient we sometimes open, or just leave it alone for the ordinary routine cases? But I am also very specific for my junior to get ready for their cardiopulmonary bypass standby or blood in the room. This training was, I think, very fundamental in my training in the younger days. Do you think these are specific order to be depending on the patient, but how do you teach your younger generation to this setup? Do you have a setup risky level, 1, 2, 3, 4, something like that?
No, No, no,
I'm sorry,
no.
it's a general question.
No, not really. I think it's about, as I've gone through the process of describing how to prepare yourself and prepare your patient, have all the information, and then you make the decision.
Right.
And it's very rare to have to resort to exposing the femoral vessels, or if you have problems with an aortic aneurysm that's in a reoperation and it's against the sternum, then certainly you would. But in terms of the right ventricle, no. I would always start, as I've demonstrated, with that technique, because the CT scan's not that helpful. It'll always show the right ventricle as apparently being stuck on the back of the sternum, which it isn't, but it's got to be dissected off carefully. So I would always start that technique that I demonstrated. If we did have problems higher up, I think you can stop and you can half open the sternum with the saw, gently retract it, and then start to move on up again from that point. But in my experience, that's very rarely required.
I see. I usually learned to use oscillating saw rather than a striker saw, especially for the real patient, 100%. What do you think about that?
Not much.
Okay.
Sorry. I used to use an oscillating saw, and there was bone marrow, blood flying everywhere. And no, I didn't. I just think that this is a far superior technique for me. Yeah.
Thank you.
Thank you. I really enjoyed it. It was a very nice talk about risk management. More and more patients now going to a redo following a failure of PCI. So the situation will be different in terms of when you talk about contingency plan. Is there any special way, or perhaps your thought, how do you include that when a patient failed PCI and go to the surgeon because they need an urgent redo surgery? Is there any specific point that you can give us in terms of that specific situations? Thank you.
Well, I think obviously it's a salvage emergency situation, depending on what their circulation is like or whether they're in shock. So, rapid entry onto bypass. I'm assuming this is a first-time operation. Is that what you're describing, or have these patients had a previous operation?
This is there was a previous operations.
Yes.
And then there was an occlusion. There's a lot of more patients going to PCI interventions now, and then there's a failure into that.
Oh, yeah.
Is there any special way of?
I don't think so. I mean, if the patient's relatively stable, then you can proceed as described. Often in this situation, you won't know about it until suddenly they call you from the cath lab, and you're severely disadvantaged. But you have to just work in that case with what you've got. And obviously the patient's unstable, then you're still going to need quick re-entry. You might need to put a balloon pump in them, support them with inotropes. And I think that sternotomy technique that I described, I think is a fairly quick way to get into the heart, and that would still be the technique I'd use.
Thank you very much for a nice video, because I learned from Chiang Mai University, and I think that the way to rhizonotomy is exactly the same way that my teacher taught me how to do it, and I'm very impressed. But however, there is some case in a few years back that I have some problem to enter in the chest like in this technique. I go back to do like on pump first and do rhizonotomy. So actually, do you still convinced that this technique can be performed in almost every cases? And do you think that the case that first redo like mitral valve surgery or previous CABG, is it different in the managed way to the rhizonotomy between the two techniques?
Yep. You still assess the hazards that you've got, assess the risk, look at the likelihood and consequence, think of how you're going to control it. And as I said, in my experience, I can't think offhand of a situation in that last 18 or 20 years when I used this technique where we had a significant issue. But I will say there would be a very occasional patient where we might have stopped halfway up or at a certain point where I knew from the external marker using the wires and your preoperative assessment is where we're likely to strike trouble. And then you can work slowly from that point on, and you may have to resort to Dr. Asai's oscillating saw at some point, but it would be very uncommon, very uncommon.
Thank you very much, because I think in my unit, more than 80% of cases can perform this kind of procedure. Thank you very much.
Thank you very much. Okay, so thank you very much for your the participation for the discussion. So we will close this session. Thank you very much.